Hello everyone. Today we talk about postpartum hemorrhage. Postpartum hemorrhage is one of the biggest killers of women around the world. It's part of the triad of the big killers, which include puerperal infection and hypertensive disorders in pregnancy. We know that one woman dies every 4 minutes as a result of postpartum hemorrhage around the world. We also know that most of these deaths are happening in the developing world, which speaks to the fact that we can do something about these deaths, we can prevent them, and we can prevent also the morbidity that is associated with postpartum hemorrhage. Postpartum hemorrhage is quite common. It's estimated that 6% of all deliveries end up with postpartum hemorrhage. A recent audit done at the hospital I work showed that about 3.5% of deliveries that happened ended up with postpartum hemorrhage. This is probably an underestimation because some postpartum hemorrhage cases are not reported as postpartum hemorrhage. We know that around the country, in this case Zambia, 30 to 40% of maternal deaths are as a result of postpartum hemorrhage. So this is a huge problem around the country, as we may know. So what is postpartum hemorrhage? So postpartum hemorrhage is bleeding after childbirth that has the potential of causing hemodynamic compromise. And this is the definition that I would like to promote: bleeding that has the potential of causing hemodynamic compromise. The reason this definition is important is that when a woman bleeds in labor ward, all we get is the fact that a woman is pouring. A midwife calls, a junior doctor calls that a woman is pouring. That's the call we get. And if nothing is done about it, that woman will bleed to death. That call has nothing to do with the volume that a woman has lost. They're not calling because she's lost 500. They're not calling because the patient has lost 1,000. In fact, you don't want anyone to call you when a patient has already lost 1,000. What you want is somebody recognizing that if this bleeding is not attended to in time, it will cause hemodynamic compromise, it will cause morbidity, and it will cause mortality. That is what really postpartum hemorrhage is. Of course, the official definitions are that it's bleeding that is 500 mils after vaginal delivery and 1,000 mils after cesarean section. The problem with this definition is that one, that we can't measure blood loss. Normally, blood losses are always underestimated, even by experienced people. There's several studies that have indicated how blood loss is always underestimated, that we can't estimate blood loss properly. So it's strange that our official definition of postpartum hemorrhage has numbers that we cannot extract clinically on the ward. Then the other reason there's a problem with this definition is that blood loss is blood loss. When a woman loses 500 mils, whether it's by cesarean section, it's by vaginal delivery, that amount of blood will cause something, will change her hemodynamic status. So it's strange also that we have different definitions of postpartum hemorrhage depending on the route. I think that if a woman breaks her bone and loses 1,000 mils, it's not postpartum hemorrhage, but the amount of compromise that 1,000 mils will cause is similar to what hemodynamic compromise will happen if she lost that through C-section. So that is my problems with this official definition. Of course, we know that postpartum hemorrhage can be primary if it occurs within 24 hours, and it is secondary if it occurs after 24 hours. The reason for this classification is really that it gives us an idea of the etiology of the postpartum hemorrhage. If postpartum hemorrhage happens beyond 24 hours, usually it's retained products of conception, retained placental tissue, that is, and also infection, endometritis. Those are like the common causes of secondary postpartum hemorrhage. Primary postpartum hemorrhage, on the other hand, is caused by those acute events that we are going to talk about. And we know that it can be major postpartum hemorrhage when there's more than 1,000 mils blood loss, and minor when there's less than 1,000 mils blood loss. So before we move on, a little bit about the physiological changes of pregnancy associated with postpartum hemorrhage. So we know that blood volume in pregnancy increases by 50%. In fact, by the time a woman is 8 to 10 weeks pregnant, her blood volume has already increased by 25%. It has almost doubled by the time she gets to 20 weeks. The blood volume of a pregnant woman at term is about 100 mils per kg body weight. That is about 7 liters for 70 kg woman. That is really remarkable compared to a 70 kg non-pregnant woman who has a blood volume of under 5 liters. So the jump in the blood volume is really remarkable in pregnancy. So because of that, a woman has to lose 40 to 50% of her blood loss, of her blood, for her to have shock. Her pulse, her blood pressure is normal when she's lost about 1,000 mils. Tachycardia, tachypnea, drop in systolic blood pressure only comes when she's lost close to 1,500 mils. This is quite remarkable, and has killed, has been a cause of death for so many women, because people are looking at the blood pressure and thinking everything is okay when a woman has lost 1,500 mils of blood. This is, of course, is compounded by the fact that blood flow to the uterus is also increased during pregnancy. So the uterus is receiving about 500 mils of blood every minute. If you compare this to the amount of blood going to the uterus pre-pregnancy, this is about 50 mils per minute. The jump is also very high. This means that a woman can lose her whole blood volume in 30 minutes to an hour if the bleeding is not controlled. We know most of the bleeding is controlled by myometrial contraction. The uterus contracts. Those middle layer uterine muscle fibers, they contract around the blood vessels that perforate the uterus and cause hemostasis. So that is quite important, and this is the reason why atony is the commonest cause of postpartum hemorrhage and the commonest cause of deaths due to postpartum hemorrhage. Then you have this last change of in pregnancy that we want to talk about, which is a hypercoagulable state. So this I'm mentioning this because clotting really is not the major way that a woman stops bleeding from the uterus. So bleeding from the uterus is normally caused by that myometrial contraction. So a woman that is having a coagulopathy might survive if the uterus contracts properly, as opposed to a woman who has a normal coagulation and her uterus is not contracting properly. The woman who dies there for sure is the one whose uterus is not contracting. So we always have to be aware that the the basic mechanism for stopping bleeding from the uterus is uterine contraction. The clotting just comes in after the myometrial contraction has done the bulk of the work. So that is important to remember and realize. So having discussed the physiological changes of pregnancy associated with postpartum hemorrhage, we look at the causes, which have been ably classified as causes of Pph due to tone, causes of Pph due to retained tissue, and causes of Pph due to trauma, and causes of Pph due to thrombin or coagulation disorder. So we'll discuss each of these causes in turn. Yeah, so the commonest cause of postpartum hemorrhage is atonic uterus. It accounts for 80% of the causes of postpartum hemorrhage. So we have to be aware of this and act as quickly as possible to improve tone of the uterus when we have a case of postpartum hemorrhage. It's advisable to get your repeat oxytocin given, start an infusion of oxytocin. That is important because atonic uterus is really a common cause of postpartum hemorrhage, and we have to look out for these conditions that can cause that can predispose to atonic uterus. So twin pregnancy, because there's a huge placental bed, and there's overdistension because there are two babies there, so the uterus fails to contract after delivery. The same as polyhydramnios, overdistension and the uterus failed to contract the big baby. Hyperity, because the woman has had so many babies, the uterine muscle layer is kind of thin, and also that this uterus is really tired. It's had so many pregnancies before, it has had so many labors before, and it fails to contract after delivery. Of course, in hyperity, when a woman has postpartum hemorrhage, we always have to think about ruptured uterus as well. Then prolonged labors, again, this is a tired uterus. It's been laboring for a while, and then at the end of labor, it fails to contract. We have augmented labor as well. The uterus was being stimulated artificially, and after the delivery it fails to contract. It's also, this is the reason also that we can have uterus failing to contract after a post-term pregnancy. So this uterus has been distended for a while. It has gone beyond 42 weeks. And then when labor starts, when we start the labor, then labor fails to, the uterus fails to contract. So that is about tone of the uterus. The second one is trauma. So genital tract trauma is a big cause of atonic uterus. So usually you suspect this when you have a uterus that is contracted, but a woman is pouring. In those two situations, you have to try and figure out if trauma is the cause of the postpartum hemorrhage. So trauma starts up high in the genital tract. So think about ruptured uterus, think about cervical tear, examine for cervical tear, look at vaginal tears. These genital tract traumas are especially common in women who have had instrumental delivery, because usually means that their labor has been prolonged, and also the same instruments we are using to pull out the baby have they cause a lot of genital tract trauma, vacuum, forceps, and so on. Of course, forceps more than vacuum causes genital trauma, and usually these conditions are handled by identifying the type of genital trauma you have and surgically fixing it. Then we have causes due to failure of blood to clot, or what is called thrombin in our 4T mnemonic. So conditions like preeclampsia will cause can cause DIC, intrauterine fetal death can cause DIC, abruptio placenta can cause DIC. A woman that has bled massively can end up with failure to clot. We always have to think about patients who are on anticoagulant. We are giving prophylaxis for deep vein thrombosis, treatment for deep vein thrombosis, people on some aspirin. All those patients, we have to think about problems of bleeding due to a coagulopathy. Then we have retained tissues. So retained placenta, the placenta accreta spectrum is also a big cause. For tissues, really, the problem I find is that most people after delivery don't examine the placenta. So if the placenta is not examined when you have a postpartum hemorrhage, then you go back to checking are there any placental tissues in the uterus and so on. So you delay quite a bit. So examining the placenta at the end of the third stage of labor is very important, because in case of PPH, for sure that there's no placental tissue in the uterus. You can move on up the ladder to look at other things that might be causing postpartum hemorrhage. So if we don't do that properly, we delay the treatment when a woman ends up with postpartum hemorrhage. So how do you manage postpartum hemorrhage? There's several ways of looking at that question, but the most important thing when you are managing postpartum hemorrhage is to stop the bleeding. Do everything you can to stop that bleeding. And one of the most underutilized resources in stopping the bleeding is doing an abdominal aortic compression. If you put pressure on that aorta from the abdomen around the umbilicus, the bleeding will stop, it will reduce, and it gives you time to do several other things, to examine the patient properly, to do things, call everyone, and so on and so forth. So that is quite important. It's very highly underutilized, but it's a way that we can stop the bleeding before we do something else. Then you have to call for help. Get everyone that you can as early as possible. Call the most experienced people from the beginning. Don't wait until you've lost a liter, you've lost 1,500, you've lost 2 liters to call the most experienced person available, to call your consultant. Just start calling from the beginning. Then the other very important thing that needs to be done is your evaluation of what is the cause of the bleeding. Remember, we've talked about torn, trauma, tissue, and thrombin. So examine the uterus from the abdomen. See if there's the uterus is contracted or not. If the uterus is not contracted, start oxytocin. That is part of stopping the bleeding. Start your oxytocin. Start massaging the uterus. Give your misoprostol, give your tranexamic acid, anything you can do to stop the bleeding as soon as possible. Then do an evaluation to get to what is causing the bleeding. So it's important to do this in sequence and to do everything at the beginning. Because if you're examining one thing and leaving the patient saying, the uterus is not contracted, let's start oxytocin, then you move on, then they call you again that the patient is still bleeding, then you start checking if there's any retained tissue. That's really a wrong way to go about it. So when you are called for postpartum hemorrhage, you check, is the uterus contracted? If it's not contracted, you start working on that. You give your uterotonic agents, you massage the uterus, but go on a step further. Go and examine the inside of the uterus. Check if there are any retained products. Remove the clots that are in the uterus. Examine the cervix. Check if the cervix is intact in a sequential standard way. Then check for vaginal tears. Is there a vaginal tear in the apex? Is there a vaginal tear on the sides? Is there any other vaginal traumas that that are there. So in that one examination, you've checked the tone, you've checked for trauma, you've checked for tissue, you've taken blood for your clotting time. Usually if you see clots coming out of the vagina, it means that clotting is still there. But if you see just blood pouring without any clots, it's a sign that you have a coagulopathy. So all those things can be done all at the same time, instead of doing one thing and doing another thing later when you are called back. Then we have to respect the golden hour, meaning that the story of this woman is bleeding should come to an end within an hour. That bleeding should stop. We have an hour really to stop the bleeding. Remember that there's 500 mils of blood coming to that placental bed every minute. So an hour is really stretching it if we don't get to the bottom of why she's bleeding and arresting it. So we have this 1 hour to get this bleeding over and done with. The cause of the bleeding should be known, and we should be doing something about it by the end of an hour. And if possible, the bleeding should end within an hour, so that we can continue with the supportive treatment. We need to inform theatre, like I've said, blood bank consultant, way before the patient deteriorates. Many patients die because people want to try this and try this before they get the information around. Get as many IV lines as you need to treat this woman, one for oxytocin, one for fluid, maybe one for blood, and so on. Get all those things. Get blood sooner than you need it. If it's not needed, you can take it back. That's fine, but don't wait until the woman has deteriorated for you to get blood and ask for it. If you've lost a liter, 2 liters, a woman in shock, most patients do badly because we are always behind with fluid. So if a woman has lost 2 liters, it means and she's in shock, for you to replace it with a crystalloid, you need to give her 6 liters. So that ratio of 1 to 3 should be considered. We have sometimes shortage of staff and so on, but we should always remember that everything we are doing, we need to record. Sometimes we have a maternal death and there's no information in the file on what was done and so on, and people might interpret that as mismanaging the patient. So because there's nothing in the file saying what we exactly did and so on. So finding someone to record all the information, keeping track of time is quite important when you are managing these patients, because you can be there trying to suture a cervix for 2 hours and the woman is pouring and you didn't keep track of the time, because time moves really fast, and when you have an obstetric emergency like this, you can't, it's difficult to keep track of the time. So that was about managing postpartum hemorrhage. Thank you for listening, and we'll see you next time.